Good morning, good afternoon, and good evening to everybody from around the world who's joining us today on behalf of the Wiskott-Aldrich Foundation. I'm very happy to welcome you. I'm Sumati Iyengar. I'm the co-founder and executive director of the Wiskott-Aldrich Foundation. Thank you for joining us today to hear the first really full talk on the clinical spectrum of VAS carriers. Our speaker for today will be Dr. Suhag Parikh. Joining him will be Dr. Shan, who's also an author on the paper, and our moderator will be Dr. Fabio Candotti. As we can see by the number of people listed on the slide, it's a huge number of people who have worked. It's a number of people who have worked to make this study possible. Most importantly, it was due to all of the carriers who voiced their concerns and made this possible, especially today on Rare Disease Day. Thank you for joining us because today is Feb 28th. Thank you for all for wearing your stripes and your colors. You voiced your concerns and made this study possible and responded to the survey. While we spearheaded the survey, the Wiskott-Aldrich Foundation spearheaded the survey, it was made possible by the PIDTC, the IDF, the NIH, and so many other organizations. I'd like to especially call out Dr. Shan, Dr. Adriana Westbrook, David Hagen, who made the study international and possible, Dr. Mungorian, who made the mental health study possible, Chris Kalchunis from the IDF, and Hans Sachs, who has always been with us from the very start, and our last author on the paper and our speaker for today, Dr. Suhag Parikh. Dr. Parikh and Dr. Shan and Adriana have spent an enormous amount of time making the study possible. I'd like to call out a special thanks to many of our families listed here who spent the time to make the survey robust and did beta testing on the survey, and to Brannon, who's our tech support. I'd like to call out Mike Skronecki, who's the chairman of our foundation, who's joined us here today as well, without whose leadership this wouldn't have been possible. So just a quick word about the Wiskott-Aldrich Foundation. We're a nonprofit dedicated to improving the lives of families affected by WAS worldwide through research, through education, and through family support. A few housekeeping rules. The meeting is being recorded, so if you would like not to appear in the video, please turn your video off. Please change your name. Please place yourself on mute unless we're chatting, and feel free to post your questions on chat, and time permitting, we'll open the floor to questions and discussions. A disclaimer, the information presented during this session does not substitute the medical advice, treatment from your or your child's physician. Each patient is unique, and the information presented in this session may not be applicable to every patient. Always consult with your physician with questions about your or your child's health or condition. Do not disregard medical advice from your physician or delay seeking treatment based upon the information presented in this session. With that, I will have the honor of introducing Dr. Fabio Candotti, who is he's a professor, full professor at at Lausanne Hospital in University of Lausanne in Switzerland. He is the head of the Division of Allergy and Immunology, and more importantly for us as Wiskott families, he's the chairman of our scientific advisory board. He's been with us since the inception of the foundation. Dr. Candotti, thank you for leading us in all our scientific and educational activities. I'll let you take it from here.
Great. Thank you very much, Sumati, and welcome everyone to this first opening lecture of what will be a series that we've done in the past that we want to restart because we thought that was very successful and very helpful to many of us. As Sumati said, I don't have much to say. As Sumati said, we're going to have a presentation by Dr. Parikh. They will present the finding of the survey, and then we'll open it to questions. If you put your questions in the chat, we can read them from there. Otherwise, if you prefer to speak later at the end of the talk, we'll give you space for doing that as well. Now it's my pleasure to introduce Dr. Suhag Parikh, the senior author of the article, the publication, and please, Parikh, take it away.
Thank you, Dr. Candotti. I am just going to share my slides. Great. So thank you so much to the Wiskott Foundation and Dr. Candotti, Sumati, and all the members who are here today on the weekend to, have this discussion about the problems that carriers of X-linked Wiskott-Aldrich syndrome can have. So Dr. Shan Chandrakasan, myself, Sumati, and many of the organizations that are listed here, PIDTC, Immune Deficiency Foundation, and Hyper IgM Foundation, all of us collaborated and created the survey, and also over the years analyzed and had a manuscript. And I'm going to share the salient features of what we found today. And hopefully we can answer some of the questions and make some progress towards initial steps of how we can apply the results of this survey for some meaningful benefit to the carrier community. So as you all know, Wiskott-Aldrich syndrome is an X-linked combined immune deficiency due to a genetic defect in the Wiskott-Aldrich syndrome, or the WAS gene. And traditionally, we have viewed the patients who are very severely affected as classic WAS. And the main features of this syndrome are microthrombocytopenia, eczema, and severe infections, and in many patients, autoimmunity and hematologic malignancies. There are patients who have milder disease that traditionally we have called X-linked thrombocytopenia, or XLT, who typically have, at least in early life, thrombocytopenia and eczema, and maybe mild infections. But over time, they can develop the same severe problems that classic Wiskott patients have, such as autoimmunity and malignancy. This is a scoring system that was developed earlier by Dr. Ox and his group, which is widely followed for practical management of patients. In this scoring system, as you can see, a score of 1 up to 2 is considered mild and is consistent with the designation of X-linked thrombocytopenia, whereas a score of 3 to 5 is considered more severe, and those patients are regarded as classic Wiskott. Dr. Michael Albert's center in Munich has followed patients with Wiskott for decades, and this is a slide showing the natural history of Wiskott X-linked thrombocytopenia patients. And what you can see here is that the overall survival of these patients is not very different from the general population, but the event-free survival, and by events, we mean very severe infections or malignancy, autoimmunity, and dying from the disease. So the event-free survival is very poor, and the number of events keep increasing steadily over the years. So this is a little bit misleading, the designation of XLT in that sense. Recently, the European group, including Dr. Albert's center, they analyzed the genetic information and correlated it with the clinical symptoms, what we call as genotype-phenotype correlation. And they found that certain types of mutations predicted a very mild, somewhat milder course as compared to other types of mutations. So these class 1 mutations, which predominantly are missense mutations, they tend to be associated with a milder disease, whereas the class 2 mutations tend to be associated with a more severe disease, have more events. And this is far more objective than the classical conventional designation of Wiskott versus XLT, and may be a more reliable way in the future to predict the disease course. And so now there is a new thinking within our immune deficiency physician medical community about maybe paying less importance to the designation of classical Wiskott versus XLT, but maybe consider all the patients as having Wiskott-Aldrich syndrome, and then determine or predict the severity based on genetic information. So, obviously, Wiskott is a very life-threatening and a serious disorder, and that's why We talk a lot about it. We study a lot. We have done transplant, hematopoietic transplant or bone marrow transplant on many of these patients. And this slide here shows the most recent publication from our consortium, which is called PIDTC, Primary Immune Disease uh, Treatment Consortium, where in more than 300 patients, we showed that the survival is pretty good. If you are less than 5 years of age, the survival is 90% or more. So that's a pretty good outcome. However, that 10% or 15% of the patients who don't do well, they have lots of problems. And so there's an alternative form of cell therapy, which you all may be aware. It's called gene therapy. And gene therapy is less toxic in the near term, so there's a lot of interest in that. The efficacy has also been established in this study from Milan, and this product was just recently approved, and I know that the Wiskott community is very excited about this. So we talk a lot about Wiskott because of its life-threatening nature, but what we don't usually pay much attention to is the carriers. And like there are many diseases in which the carriers are not affected at all, but that may not be the case with Wiskott, and not much is known about it. There are other X-linked diseases where there's variable degree of involvement of the carriers as well. So along with Wiskott, there is a need to probe into X-linked carriers as a whole. There are a lot of questions in the Wiskott community, especially the carriers, whether they have any immune problems, whether they have any bleeding risks, cancer risks, or any specific issues related to pregnancy, and what is the mental health impact of all of this. So for any discussion about X-linked carriers, it's important to at least briefly review lionization. Lionization basically is a phenomenon where one of the X chromosomes, so just so everybody knows, females have two X chromosomes and males have one X and one Y chromosome. So there is a little difference in amount of protein produced because of this phenomenon. So naturally, there is a inactivation of one of the X chromosomes in female cells at an early embryonic stage, and this is called X chromosome inactivation, with the purpose being to avoid double gene dosage in the females from the proteins that are on the X chromosomes. And this process is typically random. In other words, about 50% of the cells will be expressing the normal gene, and the 50% of the cells will be expressing the abnormal gene. And it is generally sufficient for females to avoid any major clinical problems. But there are times when it is not random, and that type of presentation is called non-random X chromosomal inactivation, or skewed or extremely skewed X chromosomal inactivation. And it could just be a random part of the process, but it could also be because of significant survival advantage. For example, in Wiskott, as well as in a disease called SCID, the T cells and the lymphocytes have significant survival advantage. So even if there is skewing, all the cells that you are going to find in the blood are likely to express the normal gene, because the ones with the abnormal gene do not make it. And then there are some other reasons why, genetic reasons why there could be skewed lionization, which we don't need to elaborate on in this talk. There is an apparent increase of lionization with age. In other words, there could be worsening of the situation with age in carriers, but this is something where we have very little information. It's a very limited information. It'll be really good to have prospective studies studying the longitudinal dynamics of lionization. The degree of lionization is a very important aspect to study, because by correlating the degree of lionization with the symptoms in the carriers, one could understand what is a threshold below which the carrier is at a higher risk of problems. And with if we understand that, we could be more reassured about recommending carriers to be stem cell donors for their family members. This study of lionization and correlation with the carrier symptoms can also help the medical community determine the chimerism thresholds in the setting of allogenic transplant. And it could also help us understand the efficacy thresholds for gene therapy. So it's really a very important aspect of understanding a lot of the issues related to carriers. But there is not a lot known, at least there's a lot that has been systematically published that helps us understand the problem in the carriers. There are up to about 30 to 40 patients reported in various publications that have been shown to have some degree of clinical symptoms, mostly thrombocytopenia and eczema, and some with mild immune deficiencies. Fortunately, not anybody that I have come across with lymphomas or autoimmunity, severe autoimmunity. But these patients who presented with some symptoms, most of them had extreme skewing or extreme non-random X chromosome inactivation. So in order to study the clinical burden of disease in carriers systematically, we did this particular survey in November 21 to February 22 in collaboration with PIDTC, Wiskott Foundation, Hyper IgM Foundation, and IDF. Dr. Shan and I, we were the co-investigators at Children's Healthcare of Atlanta, and Dr. David Hagen helped us with the IRB approval for patients or carriers outside of the US. This was an online Qualtrics survey that was taken by the participants on their mobile devices. The objective of the study was to identify the incidence of clinical problems such as thrombocytopenia, autoimmune diseases, malignancy in the carrier population, and also to get a sense of the mental health issues such as anxiety, depression, and guilt. And the secondary objectives were to increase the awareness of the problem in medical professions, and also to, with this information, to create some guidelines for the carriers and explore the role of carriers as stem cell donors for their family members. The survey had 68 questions, which were in different categories, including the relationship of the carrier to the patient, the type of the mutations, demographics, the clinical burden, pregnancy-related issues, and psychosocial issues. A total of 193 carriers participated in this survey. They were about half of them were in the US and the other half outside. 73% or majority of them reported themselves as white. And the median age of this cohort was 39 years, with the oldest carrier age was 74 years. Majority of the carriers reported as being mothers of Wiskott patients, with sister and daughter being the second most common. And about 30% of the carriers reported having more than one Wiskott member in the family. And 9 of the carriers reported as being transplant donors for members in their family. When we asked about the severity of the disease, and we used the traditional definition because when we designed the survey, we did not have the information about the genotype. Majority of the participants stated that they had the severe Wiskott in the family, 69% of them, and 18% reported as mild disease, 7% reported as having both types of Wiskott in the family. The overall medical burden, there were several questions asking about symptoms in different systems. The most common symptoms reported were in the skin, blood, and the joints. Um, uh, and the skin, and they were all reported by more than 50% of the patients. We also asked a separate series of questions asking them whether they had any significant illnesses in the family. And fortunately, the incidence of significant illnesses was not as high as the symptoms reported. For example, endocrine uh, system was mostly reported, mainly hypothyroidism, and the incidence was still less than 20%. There was another question that was asked, which said that would a carrier consider themselves as healthy? And fortunately, 80% of the carriers reported that they considered themselves healthy. So what I think that means is that while there are lots of symptoms, it's reassuring that majority of the carriers with a median age group of about 30, 40 are still reporting themselves as healthy. Um, the digging deeper into the questions in the hematologic systems, anemia and thrombocytopenia were the two most common um, uh, uh, sim, uh, symptoms reported. Anemia is fairly common in women, so we focused on thrombocytopenia because that is one of the problems in Wiskott-Aldrich syndrome. So our questions were more detailed about thrombocytopenia, and we found that overall, when you define platelet thrombocytopenia as a platelet count less than 150,000, the incidence was about 13%. Um, and if you ask about more severe thrombocytopenia, some of the patients did have that. For example, 2% of the patients had platelet counts less than 50,000. At this level, patient carriers can get symptomatic. So this is kind of important to know that there are 2% of patients who carriers who can get thrombocytopenia, which is severe. And 3% reported that it was chronic, that it was not intermittent. The age at the time of diagnosis of thrombocytopenia was between 21 and 30 years in majority of the patients. And some of them did need treatment such as IVIG, platelet transfusion, and steroids. Looking further into the skin manifestation, the two most common symptoms reported was easy bruising and atopic dermatitis or eczema. And the infections such as athlete's foot and warts and molluscum, so they were present in a minority of the carriers. We especially asked about infections. So skin infection, ear infection and sinus infection were the two most common infections reported. But about 1/3 of the carriers said that they had frequent infections. And, and actually majority of them also, the ones with the frequent infections, said that they were either stable or not, or getting worse. So clearly there is a high burden of infection in this cohort. And 8% of the cohort had required hospitalization for treatment of infections. Regarding allergy, about 50% of the carriers reported having allergies. Majority of them had environmental allergies, and some of them had food allergy, medicine allergy, and asthma. And there was also concern about autoimmunity. So we found that about 1/4 of the carriers reported having autoimmune diseases. The most common ones were thyroiditis, rheumatoid arthritis, psoriasis, and immune-mediated thrombocytopenia, or ITP. Regarding cancer, about 20 carriers or out of 193, so 10% of the carriers reported having cancer. The most common one reported was breast cancer, which was in 5 carriers, skin and thyroid. And there were several other types of cancers which happen in 1 or 2 carriers each. The median age at diagnosis of cancer was 41 years. What is important to note is that we could not identify a single case of lymphoid malignancy or leukemias, which is very reassuring. Regarding pregnancy, the questions asked whether there was a miscarriage or excessive bleeding after birth or drop in platelet counts, or whether the pregnancy felt different compared to the prior pregnancies. And this is the data. About 1/4 of them reported having miscarriages, and a fewer percentage reported having bleeding, say 10%. And 13% reported having drop in platelet count during pregnancy. So about 60% of the carriers reported having difficulty at work, home, school, or in interacting with people around them. So clearly significant impact on day-to-day life. Also, about 40% each reported symptoms indicative of depression or anxiety. One of the most important findings for me at least was that there was a significant amount of guilt, both in passing the gene to the son or to the daughters, almost 90%. And also there was concern amongst carriers that they had not a good amount of information from the healthcare system. About 1/3 of them felt that their physicians did not provide them with enough information or did not understand enough about their health status. About 1/3 of the carriers felt that they did not get enough support or guidance for genetic testing of their daughters, and about 15% felt that they did not get enough guidance for future pregnancies. So in summary, fairly high proportion of VOS carriers reported significant medical problems. And here's a summary of the main items that we found. Thrombocytopenia was noted in 13%, and on the right in the red is the incidence or prevalence of thrombocytopenia in the general adult population. And you can see it is quite a bit significant compared to the general population. Same thing, eczema was found in about 22%, which is higher than the 10% found in the adults. Infection was found, recurrent infections were noted in about 1/3 of the carriers. I have not included the data. It's difficult to compare infection, but we have looked at some publications and find that this infection rate is higher than the general population. And similarly for autoimmunity, the incidence is higher than the adult female population. Reassuringly, the risk of cancer is not very high compared to the general population, but obviously that is something that needs ongoing surveillance. And then we saw that the psychological stressors we don't appreciate, and what the origin of that psychological stress is. It because of the symptoms experienced by the carriers, or is it because of the caregiver responsibility? So all of that is something that needs to be probed further as well. So we certainly need to collaborate based on this data to see what kind of guidelines and recommendations we can give to the physicians. And so this is a slide where I have just put my thoughts, and I don't know the right answer, but this is a start to thinking in this area. So it may differ whether you are whether carriers are symptomatic or asymptomatic. For example, here are some ideas. So for example, for thrombocytopenia, I recommend that we at least monitor a blood count annually if the carrier is asymptomatic. And for symptomatic carriers, obviously, it would depend on the degree of symptoms and many other factors. If someone is very symptomatic and has mucosal bleeding or bleeding during pregnancy, then they should be managed with antifibrinolytics, or in most severe cases, even platelet transfusion, similar to how we would manage a Wiskott patient. So these are all, currently there is no systematic study, but it seems to me like this is appropriate. For infection at baseline and at immune studies would help characterize the immune function, and whether there is a role in monitoring the immune function periodically. This is will probably depend on what we find at baseline, whether there is a strong history of involvement in the family, etc. Which carriers do we recommend antimicrobial prophylaxis? Again, is going to depend on what we find in the immune function test. So we need to define this area. Whether there is a role for screening of autoimmunity on a routine basis, again, is unclear, but for symptomatic carriers, certainly screening should be done. Whether there is a role for testing urine for proteinuria to screen for things like IgA nephropathy, etc., that is also something to weigh in. Malignancy screening, as far as I am aware, there isn't strong data here to suggest there's increased risk. So definitely standard surveillance is should be done, but whether we have higher risk will become apparent with more follow-up, and whether there is whether there's a higher risk of mortality without an increase in the incidence is something that needs to be studied. So with that, I think I'm going to hand over to Dr. Shan, who will talk a little bit about the research aspects in this area.
Thank you, Dr. Parikh. Again, a lot has already been done, and I think this is a very important first step. The Wiskott community as a whole has come together and helped us get this type of information so that we can take it and make it more refined. So within us, that means within Wiskott community, leadership with Sumati and rest of the Wiskott Foundation and us, have been thinking, where do we take this from the survey study, and how can we make even more meaningful contribution so that we can come back with much more data-driven guidelines and recommendations. So what we are hoping to achieve with the follow-up study is validate the symptoms and disease burden. In addition to the survey, we are hoping we could have a provider or a nurse practitioner-driven survey or interview so that we capture a broad domains that carriers have expressed concerns based on the initial survey. And also to quantify this, can we also get access to de-identified medical records in a limited way to be able to validate some of the survey concerns that the carriers have brought up. Additionally, for us to be able to tie in, this is all related to Wiskott, and additional immunology studies could also help us to understand how much of this symptom burden we can go back and link it to objective immunological changes that we are seeing. And by doing all this, we could help develop guidelines and recommendations for what is the type of testing, how frequent, or what type of testings that need to be done to be able to capture additional morbidity in carriers. Next slide. So the immunology studies have, the carrier part of the studies have been ongoing, and the European colleagues have been doing this in Italy, and have identified about 10% of the carriers have, as Dr. Parikh mentioned, how the skewing can be significant, can have extreme skewing of the Wiskott protein in stem cells and myeloid lineage. And some of these carriers are the ones who are prone for thrombocytopenia. But however, there is opportunity to study this problem in more broad details rather than just limiting it to Wiskott protein skewing in different immune compartments. What we are hoping to achieve is to develop a comprehensive immunology and hematology evaluation In that, we will be able to look at the, in addition to the carrier reported symptoms, we can go back and look at what is the true infection risk in carriers and what is the basis behind it. And the same is true for allergies, autoimmunities, and the bleeding risk. Next slide. Over the last few years, we have already done within the carrier community that we have in the Atlanta region, we have looked at the different immune cells expression of Wiskott protein in carriers. And as we all know, overwhelming majority of the carriers have the T cells, B cells, NK cells. These are the different immune compartments in our body. They prefer, and there is a several advantage of the Wiskott expressing allele in our carriers. So you'll tend to see near normal looking T cells and B cell Wiskott expression. But in a minority of them, the peak that you're seeing here is what we see as normal Wiskott expression in healthy controls. As you can see, if someone is Wiskott-Aldrich syndrome and deficient, they'll have less protein. And if we can highlight the monocyte compartment, where you can see a very small fraction has a tail, that is a fraction in which the myeloid lineage, that is monocytes and neutrophils, have a negative Wiskott fraction. In that, we could see it's like less than 5% of the cells. So in majority of the carriers, you see this favoring the normal Wiskott allele. But it's also well known a subset of these carriers have the monocytes and stem cells have what we call as a bimodal population, in which we will have on the stem cells, there is more and more Wiskott negative stem cell that survives, and that has been shown to be associated with more thrombocytopenia. Our goal is to systematically evaluate across all lineage and also look at the regulatory cells, not just globally, just T cells, and also look at monocytes, dendritic cells, stem cells, and platelet count, so that we develop a comprehensive map of how the Wiskott protein is expressed across different immune cell lineage in these carrier states. And if you do it longitudinally, we can also see how these are changing with time. And that can give us a very good idea about what type of recommendations we need to make if you're able to follow this longitudinally. Next slide, please. When you combine that data with immune health evaluation, when I mean immune health, what we're hoping to do is a complete blood count on all carriers. Right now, we don't have a comprehensive understanding of if you do an immunoglobulin profile, these are proteins that help fight infections. What proportion of our carriers are actually having low immunoglobulin levels even at baseline? If they're having normal immunoglobulin level, is in addition to quantity, is the quality good? Because if you look at the survey, 1/3 of our carriers are reporting increased infection. That is among the highest. And more importantly, they're reporting both sinus and ear infections. Those tend to go with if our body is not making good quantity or good quality or combination of both immunoglobulins. So I think it will be important for us to be able to look in a more systematic way across the board, all carriers, and see whether they make good amount and also good quality of immunoglobulins. We can assess quality by checking vaccine titers. And also we can also look and see whether the B cell maturation that ends up making immunoglobulin is age appropriate or not. Similarly, we can also look at whether even though the T cells might have normal looking Wiskott protein, whether the regulation of the T cells or the B cells together are looking reassuringly normal or not. And in classical Wiskott, there is also, in addition to the immune deficiency autoimmunity, there have been publications on they have heightened inflammation. So we will also want to look at something similar in the carrier community to see whether that is still a concern in a subset of our carriers. Ultimately, because there is also concern about autoimmunity, we were hoping to look at more broadly ANA and other well-established markers of autoimmunity in our carrier community. So if you're able to do it consistently, like we were impressed with 193 carriers who have taken the survey, even if a fraction of those carriers end up participating in a more global study like this would be the type of data we would need to come back and say, what are the type of testings we should be doing as a screening test in all our carriers, and who among these carriers need additional evaluation and medical attention, right? And and outside of the carrier health themselves, then if a carrier is known to be a donor for one of either their sibling or other family members, we could even say, is this a carrier that we feel confident at an immune level is healthy and has unskewed stem cell population that we can feel confident? Again, this type of data will mature with time, but at least currently we are doing it in the blind. It will be good to have these type of information so that we have more informed and well-educated decision making. Next slide, please. So we have partly done this in other X-linked immune deficiency, at least in one of the, this is an international collaboration with European Center and also Dr. Parikh, myself, and the rest of my colleagues in Cincinnati Children's. We have had patients where there are X-linked immune deficiencies, where sister has been known to be a match but is also a carrier. By doing more detailed immunobiology studies, we have also assessed whether the carriers are healthy and whether these carriers could be reasonable donors for stem cell transplant. I won't go into the details of these because these are not directly relevant to Wiskott-Aldrich syndrome, but I can say based on more detailed immune studies, we're able to show certain critical immune compartments have actually a very normal profile in carriers, at least in the carriers we have used as donors. And based on that, we were able to make decisions on, yes, this carrier could be a donor for stem cell transplant. And we're happy to report when the carriers were used for transplant for this condition, the recipient immune system has been working really well without any long-term complications. So I think these are the type of studies we would also need for the Wiskott to be able to tell in a more informed way whether a given carrier could be a donor or not. Again, these are not 100% foolproof, but at least this is at least some data-driven decision making rather than empirically saying a carrier cannot be a donor for a sibling who needs a transplant. Next slide. So what we are proposing is, again, we have done a more institutional level study locally to be able to show feasibility. We have developed all the tools to be able to do it. But I think in a more broader way, if we have support from the community, we could do more comprehensive studies, as I said earlier, a physician or a nurse practitioner administered survey with an interview using a secure online platform, and following that with some degree of validation if we have a significant medical history, if you're willing to share some of the de-identified data. Additionally, we were planning to have, instead of a carrier coming to a physician's office for blood draw, how can we have home-based assessment and blood draw and have both immune and genetic evaluation? Preliminary, we are thinking about age between 12 to any adult who will be willing to participate. But as I discussed earlier, I've listed some of the studies that we will be able to do. And additionally, we really do want to wrap this and come back to the carriers and able to share whatever we find at an individual level to be able to, again, these are research studies. I want to make sure our team, if we do the studies, we will not be making clinical recommendations. But if you find something abnormal, that's something that you take to your physician and follow up and say you might need to have additional testing. So that's the goal. Again, if we are able to achieve this, I think this would be the next big step that we can use data-based information to be able to guide what type of testing, who needs additional care, and more important, in addition to the carrier health itself, down the line, I know as carriers, many of you would have been evaluated for being a donor for a sibling. So for all those situations, I think this would be extremely helpful. And this could be one of the ways where it's not only helpful for Wiskott community, but other excellent carriers. This would be a pivotal study for them. So I'll pause here and again thank Sumati, Wiskott Foundation, Dr. Parikh, Dr. Candotti, and rest of our team for giving this opportunity for us to present.
Well, thank you very much, Dr. Parikh, Dr. Shan, for these presentations. I think we have at least 10 minutes for trying to answer some of the questions that have come in. I'm going to go in order, so to try to give space to the people that have written their questions in the chat. The one question deals with basically hives, and I don't know if this was one complication or that was. I don't think I've seen it in the list of complications that carriers females have reported. Dr. Parikh, was hives one of the complications?
Yeah, yeah, actually, I'm just pulling the slide. There were, I think, along with eczema, um, so there were 22% who reported having eczema, but hives, urticaria, angioedema was reported by 7%, and also chronic itching by 8%. So if you add these together, we actually did analysis of atopic diseases. So we combined these three, and we found about 30% had evidence of atopic disease. So I think hives is not uncommon. That's what I would say.
Yes, yeah. That looks like it. Another question, and either of you, Dr. Parikh, Dr. Shan, if you want to chime in. Another question had to do with the risk of miscarriage. Is that increased in carrier females of Wiskott?
So we did see we did see 26% reporting miscarriage. I think that it will be difficult to I don't know the comparison in the general population, but it does seem like fairly high compared, 26% is like 1/4, and that seems to be high.
Right,
Yeah.
and in theory, since a pregnancy is a situation of tolerance, and if the immune system is activated in Wiskott patients, it might be more difficult to induce tolerance, and therefore potentially one can find a immunological reason for it. Dr. Shan.
No, I was on similar lines, but again, those would be the type of situations if we can validate at what level of pregnancy is this miscarriage, and if we have additional immunobiological studies, we can see if that carrier looks at every level immunologically normal or healthy, and there is no inflammation. Then we need to think through, are there other things that Wiskott protein are critical during the placental formation, or other things that we typically don't understand at this point, because that's not the focus of boys get it's been a male disease for long, so we never have studied pregnancy in that context. So I think in that sense, it might be something that we might need to understand more. So, and these would be type of things that is mice model for this to be able to understand. But I think this gives us what we need to study more. And this being such a high incidence, it might be good to go back to mice and also try to understand, is there anything more that we can do?
Yes, it's true. Many questions among the ones that were sent in had to do with the question from Wiskott carriers, what should we do in terms of precautions to avoid complications, or what kind of management, what kind of monitoring, and one of the questions that was put in the chat is in that kind of line. If a woman that had a Wiskott boy has autoimmunity, does the treatment changes whether or not she's a carrier or a non-carrier?
So I am not sure what I would recommend regarding precautions for miscarriage other than the general precautions. Maybe let the obstetrician know that there is a higher risk reported, at least in the survey form, and general care that is needed to avoid or treat the carrier as someone who has a higher risk, which means probably more rest, maybe checking blood counts more frequently to see if there's any issues and things like that. Um, I couldn't follow the second question. So if the mother is a carrier, is there a higher chance of
Is the management of a condition of autoimmunity different
for the
if
mother for the
for
mother
the mother?
carrier?
Exactly.
Um, uh, Again, I don't. I think if the carrier has autoimmunity, then that needs to be treated like anyone else. But I don't know if there's anything specific about Wiskott. It may
Um,
be that there is a specific type of autoimmunity that comes with Wiskott. I know that in males we see IgA nephropathy, but I don't know. Again, at least in the survey, we didn't see that signal. Yeah.
So in my mind, it depends, as you said, from the depends by what kind of autoimmunity it is. In Wiskott patients, they are not treated. Of course, we worry about immunosuppressing them because we know that the immunosuppressant can have a stronger effect and causing a susceptibility to infections. For a carrier female, I guess that kind of reasoning could be valid if the female had an immunodeficiency. So I would certainly mention to my physician that I'm a carrier, and perhaps some study of the immune system are justified before starting immunosuppression. But again, like Dr. Shan said, these are the field where we need to gather more information and really try to find out what is the extent of the immunodeficiency and therefore of the risk of immunosuppression in carrier females. There was another question about, excuse me a second. Yes, so I think a mother was a donor for their son, for a brother and a son, if I understand that correctly.
Correct.
And now the mother has been diagnosed with Sjogren's syndrome. Does that mean that she has passed the risk of Sjogren's to the brother and the son? What would you say?
um, Again, these are difficult questions to answer, but what I would also consider is when you think of autoimmune disorders, especially lupus, the type of rheumatoid manifestations with Sjogren's, they tend to be more in female. And so when we think about autoimmune risk, there is a genetic component or a polygenic component to it. But in addition, is that risk likely more because of the female sex itself? So that part, because the stem cell is going back in a male, we don't know whether the same environmental factors that drove an autoimmunity is also at play in a male when the same stem cell goes in. But the risk and concerns are valid in that if there is a reason why the immune system over time has evolved to an autoimmunity, will the same thing could happen in a different environment? That is hard to answer. But that might be something to still keep in the back of your mind. But additionally, like again, depending on what type of stem cell transplant was done, whether it's a T-deplete transplant in which you remove all the immune cells and mainly give stem cells, uh, maybe the immune development in the recipient might happen slightly differently than how it happened in the donor. So those are unknown factors because we are modifying the immune cells and stem cells that we put in. And also the environment the new immune system would be developing is a totally new environment. Many autoimmunity, especially in a non-genetic background, is a combination of factors. It's just not one factor that leads to autoimmunity. I would consider we might still need to keep that in the back of our mind if there are unusual symptoms. Sometimes if there's chronic GVHD, can sometimes look like Sjogren's, right? If that happens, then we might need to think more. Maybe this is not just chronic GVHD. I might need to think a little bit more out of the box. Outside of that, my hope is because in some centers they do T-deplete graft or graft manipulation. Especially, I'm thinking if mom gave it to a child, it's either a post-transplant cyclophosphamide or a T-cell depleted graft. They might have decreased that risk immediately. But in terms of long-term risk, those are things that we need to still understand and follow up.
Yeah, I would just add that so there are some general risks in a female, and then whether we believe that Wiskott carrier state predisposes to this risk. If it is the Wiskott carrier state directly predisposing, then I think at some point you do have to worry in the long run. But but I think that it's very difficult to sort out because these diseases are polygenic often, so we can't sort out very easily. I think, like Shan said, close follow-up is what is the key.
Right. I agree with both of you, but my two words answer would be not necessarily. There are many components, and I wouldn't worry about being a donor of a Sjogren's syndrome to the recipients. There are other questions about transplant, but maybe we keep for one of the next seminars that will be dedicated to transplants. I wanted to go back a little bit on the issue of monitoring for complications because this was very, very prevalent among the questions that were sent in. And you, Dr. Parikh, you mentioned that, but if you can just summarize what you would recommend to a carrier females uh, of, in terms of monitoring, in what sense and how frequently.
Yeah. So hopefully this survey provides some sort of sense about what kind of problems to expect. But my sense would be that everybody should get at least an annual physical with their primary physician, and at least get blood counts, blood chemistries, um, maybe a urine protein. At least those three I would get, and because of the concern for immune problems and infections, I also think that at least at some initially as a baseline, we should get some immune evaluation. If they are completely normal and if there are no symptoms, then maybe they don't need to be followed so closely. But if there are infectious concerns and if there are some abnormalities in the immune function, then we at least monitor them closely. Again, there's a lot of judgment involved in this about how frequently to do, etc. But this is my thought at this time. Uh, Without data, it is very hard to make any more concrete um, recommendations.
All right, Dr. Shan, anything to add?
No, I would, I second what Dr. Parikh said. The survey has given us tools to, at least in the past, when carriers went to their physician with symptoms, the general prevailing concept is overwhelming majority of the X-linked carriers are healthy. Like, at least maybe in medical school, we need to do better in trying to uh, inculcate to physicians that could be fairly symptomatic carriers. I think the survey could be a tool if a physician, if a carrier feels like they have symptoms and they are not being heard or being dismissed, at least this offers tool to go back and say the symptoms are real. But when we follow up with additional, more definitive studies, I think we could come back with more definitive management. The only things I was also thinking is, when would a carrier, I think there was a question list, be considered a Wiskott? Like, I think that's a very provocative question. So for me, again, if a carrier starts to get platelet counts in 20s, 30s, or significant autoimmunity that needs significant immune suppression or has immunoglobulin replacement, those are overlapping with what a true Wiskott patient would have in terms of symptoms. I think those would be type of patients who would need to think through more. Do we still call them just carriers, or what type of management? Because at least in US, they have implication as to, for insurance, will they cover management of these type of things or not? I think that is a slightly different question than what was posed, but because that was another question in the list of questions that was submitted, I thought that will be good to hear from Dr. Candotti and also from Dr. Parikh.
Yes. Yeah. So we are already 5 minutes over time, but Sumati, you said it was a good question, but I don't know which one you are referring to that we
There,
want to.
there was one question because they're currently thinking about transplant, so I think it's important to answer it. Mom asked if she can be a donor if she has vasculitis.
It, but you know, this is okay. I'll let Dr.
No,
Parikh and Dr.
please.
Shan answer. But I mean, can is yes, should is different. Because you know, as we would probably talk about when we talk about transplant, in carrier females can be donors, but if there are no more ideal donors, that's more or less the conclusion, the current conclusions of the community, the treatment community. Vasculitis, it really depends what kind, what type. There are many different kinds of vasculitis, more or less severe. It wouldn't be, to me, the first choice to ask a mom that has an autoimmune conditions to be a donor, but in emergency, that could be the case. But Dr. Parikh or Shan, what would you like to answer?
I was just gonna say, like I agree with you that if the other alternative donor options are available, then I would say I would look into that. And nowadays we now have gene therapy, and there's a 10 plus years of follow-up on this study, and that is reassuring to me. So if gene therapy is available, that could be another option too.
Okay, Sumati, should we end here for this session?